So before I get into this talk, I want to make sure you understand I don't have any relationship with any company. I'm just genuinely interested in the technology. And I started working with some of them on a very loose basis, and I want to show some of the clinical applications that we have achieved so far. Why is this important? It's an emerging technology, everybody talks about it, but there are some limitations to that, and I want to get into that in terms of design, manufacturing, quality, and biological activity. In a nutshell, what works for us are three-dimensional lattice structures that have various pore sizes, and I'll touch on that throughout the talk. Pore sizes between 300, 500, and 700 micrometers are ideal for osteocyte attachment and proliferation, to the extent that potentially bone grafts may not be necessary in the future. Like I said, customized surgical solution, reduced complications and operating time, more accuracy, and the hope is that we have better patient-reported outcomes. Some of the limitations include the cost of the technology, and it's high, there's no question about that. What are we aspiring to do? Hopefully this can revolutionize the medical device industry. Think of the reduced inventory cost that's associated with that if everything is custom made. But obviously it means that there's a logistical challenge. How do you bring this from the factory to the operating room in a timely manner? Show and tell, advancement in custom 3D printed. I wrote a perspective article on that in the Journal of Personalized Medicine. I'll showcase it a few times throughout the talk. But you can see that the pore size design in the three-dimensional arrangement is important. The surface structure itself, the roughness is important. The peaks and valleys, so there's micro and nano structure aspects to the 3D printing technology that are worthwhile talking about. Here's some of the key steps. We don't have a lot of time to go through that. The big difference between these two additive manufacturing printing technologies using either a laser beam or electronic beam is one is in gas, the other one is in a high vacuum. And there's some details on how to control the laser beam, and that affects the ultimate implant manufacturing technology, accuracy, biological activity, and so forth. Here's a short video that's also in that paper, and that showcases the evolution of titanium cages. And here you see how the actual laser printing takes place. The material is added and then printed in place, and it allows to produce very complex structures that in this case are fitted to an inner body space of a particular patient. As I said, the pore size is between 300, 500 and 700, and the lattice arrangement creates an interconnected porous structure that on its surface also is by itself biologically active, and the residues from the process that are there, they're also biologically active on a nano particular level. So all of these aspects promote bone adhesion and healing, and eventually will lead to filling of the defect. And again, I'm getting back to the same comment, without a bone graft, which obviously further adds to simplifying our endoscopic surgeries. Most of those are in an outpatient surgery center, so the less stuff we bring there, the easier it is to perform, the more likely we're going to get traction with the medical community and support by our patients. A few comments on the cellular events. The image on the left shows SEM images that are stained with certain dyes. They're listed here. Again, micro and nano surface and structure properties of relevance, the surface roughnesses of relevance. The titanium actually oxidizes. In the United States, we have now electric vehicles made of titanium, the Tesla truck. And people are complaining that it's not looking silver, it's looking gold. And that's actually the oxide on the car that makes it look like it's dirty. So they want to return it, but it actually turns out to be, in our case, a useful biological application. Like I said, these are the features that are affecting cellular attachment and growth. And again, I don't want to take up too much time. It's all written up in that article. during this talk. This is the paper I was talking about. It's fairly lengthy and has a video in it as well. So the step-by-step process is pretty simple. The surgeon sends in a CT scan of the patient's spine, and the manufacturer then uses a HIPAA-compliant portal to have a CAD model created that then prints the cage. And the biggest logistical challenge is how to bring the cage to the operating room with a chain of custody that is controllable. I'm talking about sterility and that sorts of things. Here's the example I showed earlier. It goes from in A showing the CAD model, B the production model, and then the final implant in C. Obviously that solution is very expensive, so there are some off-the-shelf solutions also that are workable for most of those. For the endoscopic application, we have some other prototypes that are currently in the clinical trial phase. Do we need a bone graft or not? I think the clinical evidence, and we'll show in a little bit, points towards the fact that it potentially could be eliminated, and that would materialize cost savings that would also then justify the increased investment on the front end that we're finding as an implementation hurdle. All of these surgeries were done without a bone graft, and none of these patients failed. These are clinical trials that all show that, mostly in orthopedic oncology for cancer, congenital deformities and defects, and then a lot of studies in degenerative decompression fusion scenarios involving the spine. What does the future hold? I summarized the whole process in these 4 charts here that goes from design, the advantage of the material properties, to the cost implementation hurdles, regulatory problems, then the advantages in terms of osteoinduction and osteoconduction, and the process of additive manufacturing, which in itself is not all that trivial. Again, our article. Where I see this going is that hopefully in time we'll have something that adapts with the spine. It could be expandable or some other version of it, so we minimize problems associated with cages such as subsidence or expulsions. Perhaps we'll see sensor implication and embedding in the implants, so we get real-time data. That's been done already with other implants today. And the obvious elephant in the room, drug delivery, or biological agents that can be integrated in those implants during the 3D printing process, then via slow release stimulate biological activity. And again, the reason why I got interested in it is the ability to make custom implants that are easier to implant via guide wires in the endoscopic approach. So we're looking currently for solutions that are less burdensome and less noisy in the recovery. I do perform some standalone endoscopic fusions I'm going to talk about tomorrow, but that operation has critical limitations, and the recovery, as I said, for the patients is not that easy in the first months. So that motivated us to look into this kind of technology, and I'm hopeful that will further improve our clinical outcomes and make it easier to manage these patients post-operatively. I thank you very much for your attention.